We're going to continue on the topic of human health. Yeah. Last week, we had a very good seminar from a team that came from MIT, Harvard, and Louvain. Yeah. That talk a lot about vagina. That's what Lenin is listening me online. Yeah. And they talk a lot about the microbiome. But today we're gonna go to another subject. Yeah. Still on human health. Yeah. So our first presenter will be Karin Davidson. Yeah. Karin Davidson. Yeah. I understand that she's a nurse. Yeah. Is that right? And in her bio have a SR in the beginning, and I say, is she a sir? No, it is a sister. Yeah. Yeah. Which she did a BSc of nursing from UCT. Yeah. And then she followed to do a postgraduate degree in HIV/AIDS from the United States, yeah, and then become specialized in orthopedics, rheumatology, and inflammatory bowel disease, yeah. And then she moved to start heading what you call the Cape Town Infusion Centre in Mowbray, yeah, which is very important. We know that infusion, and you're going to be talking about anemia. I explained is affect, I think, over 50% women in Africa. What's the right statistic? Around that, yeah. And it's a big problem. And I know that some of the fellows are doing a program in anemia, yeah. So in addition to that, yeah, she's on the board of the Infection Bowl Syndrome Africa and the director of the Autoimmune Alliance of South Africa, both non-profit organizations involving research and patient advocacy and education. Yeah, and her main base it's a private clinic in the Cape Town Infusion Centre, but she was just telling me that she also works a lot with the Red Cross. Yeah, and to support anemia, both research but also infusion in South Africa. So I'd like to invite you to take and give us our first talk, and then after I will present Chris and his very fashionable team.
So thank you very much for inviting me to speak today. It is really great to be here. And I think we're going to cover a really kind of dovetailed topic in terms of anemia and Chris with his team in terms of postpartum hemorrhage. So I'm going to go ahead and dive into anemia in Africa. And this is something I'm incredibly passionate about, and really because it is an absolute game changer. When we look at the world, it is full of anemia. But I think what shouts out of this map for me is Africa and Southeast Asia, and how vulnerable we are in terms of how prevalent anemia is. And so it affects 2.4 billion people worldwide, but the majority of them sit on our continent. When we look at anemia, and you look at the green bar, that is iron deficiency anemia. So we get anemia from different causes, but the majority of the cause of anemia within the world is iron deficiency. And that is a nutritional deficiency. So it is correctable. When we look at anemia, it is not just the anemia, it is the impact it has on quality of life and on disease lost years in terms of people not being able to perform their work, people being ill, not functioning at an optimal level for their lives. And the biggest contribution again to this is iron deficiency. So this is something we can address. I'm just going to go through because I think we're a fairly mixed audience.
Can you hear online? Okay, fine. Maybe let's use.
Perfect. Okay, great. All right, so what I'm going to do is just define anemia. And I think just because everyone's from kind of mixed backgrounds, so what is it? It's a lower than normal hemoglobin. And that cutoff for anemia is based on different statistical thresholds. But what I think is critically important is that the cutoff for anemia is based on the 5th centile. Now, if you imagine a child's growth chart and your child was sitting on the 5th centile of that growth chart, you would be very concerned. So when we look at anemia cutoffs, these are not normal levels. These are way below normal. So really already when we look at those cutoffs, those people are significantly affected by their anemia. Iron deficiency is based on a number of different markers, but the main one being ferritin. And again, a ferritin of below 30 is classified as iron deficient, but that again is based on that 5th centile. So a normal ferritin level for a woman is between 100 and 150. Okay, so 30 is significantly low. And for a male, that it goes up to almost 300. So really, when we look at someone who's got a ferritin of 30 and a hemoglobin of 11, they are significantly iron deficient. There are a number of different causes for anemia, and one is inadequate iron intake, poor absorption, increased iron demand, and increased iron loss. Okay, so those are really the 4 causes of iron deficiency. And it's really critically important to look at why someone is iron deficient or anemic so that that underlying cause can be addressed and you're not just treating the iron deficiency. So that's really important because otherwise it just reoccurs. When we look at the symptoms of iron deficiency and anemia, they are huge. So we break it often into physical and mental kind of the impact of that. And physical has a number of symptoms: fatigue, coldness. We often see people having something called pica, which is craving sand or ice. And it's interesting when we do talks in schools and we say, how many of you eat ice? And all the girls put up their hands. And they buy packets of ice on their way home and they eat an entire bag of ice. And that is classic iron deficiency anemia. And so there are a number of symptoms around it. But by the time you get to physical symptoms, you're significantly iron deficient. And often the mental symptoms show up first. And that's low mood, poor concentration, brain fog, poor sleep, kind of poor emotional regulation. So we often find in our teenagers that they're really emotionally labile. They lose their temper, they're furious, they're this, and they weren't before. And that is often a sign that they are iron deficient. When we look at the prevalence of anemia in women, and this is really where I'm going to focus my talk because we are most at risk. We look at that kind of menstruation and childbearing age between 15 and 49. 30.7% of women are anemic. That is not iron deficient. So you can double that for iron deficiency. Okay? And remember, anemia is the end stage of iron deficiency. When you look at our pregnant women, 35.5% of women worldwide are anemic. And in our non-pregnant women, 30%. And then in children, around 40% are anemic already. Okay, so it literally affects millions of people. And this is one of the reasons that I think it has never been able to be addressed. Because I think the numbers are so overwhelming that everyone feels they cannot have an impact. And so we're going to come back to that later. But our most vulnerable are our teenage girls, our children under the age of 5, and particularly our very young children who are often born anemic, and our pregnant mums. But I want you to look at the figures on the left. We had the worldwide figures in the previous slide, but look at Africa. So worldwide, almost 40% of children, but look at children in Africa. Almost 60% of children in Africa are anemic. That means they can't learn, they can't cognitively process, they're emotionally all over the place, they're poor growth, they have for everything, literally, cognitive development, physical development, all of those. And in our pregnant women, 57% of women in Africa are anemic. That means they are going into delivery on their back foot. But I'm going to explain to you why there's another factor in that as well. When we look at the prevalence of anemia in children under the age of 5, if you again look at the African continent, we are incredibly vulnerable. And what's really interesting is that this data was updated this year, and South Africa moved from a moderate anemia risk to a severe anemia risk this year. And so we are not addressing anemia within South Africa either. So the reality is quality of life is significantly impacted in a huge number of our population in Africa. And this doesn't just impact quality of life, but it impacts the ability to work, to perform at work, to earn a living, to look after a family, and to keep going every day with a reasonable quality of life. But it is intergenerational. And that means it is going from the mother to the child and continuing through a life. And we really need to address it early on so that that is not a lifelong impact. When we look at the challenges in terms of anemia management, World Health put out a call a number of years ago to address anemia worldwide. They put out these amazing things by no anemia by 2025, and then had to readdress that in 2024 because they were nowhere near their targets. Then they moved it to 2030 and put a whole new updated thing to say we need to address anemia in Africa by 2030, and it's still really not moving. And so it is difficult. And when you look at this prevalence in our kind of young woman of childbearing age, we really have not improved over time. And that is a significant problem. So our anemia rates are really staying pretty static. So why is this so important to address? If we look at our pregnant mums, and let's start there, each pregnancy needs 1,200 milligrams of iron. So you can imagine if you go into pregnancy and you are already anemic, how much that is going to pull from what little you have left. So what happens is you fall pregnant, you're already anemic, your baby and placenta pull any iron that is left, and your hemoglobin just drops. Okay, so you are already at risk when you fall pregnant because your iron demand has increased. When we look at trying to manage this in pregnancy, in our first trimester, oral iron is the opportunity we need to grab. But we need to be testing in order to check if you need. But my argument a lot of the time is almost every single pregnant mom should be on oral iron. Because if you look at the figures, almost all of them are iron deficient. So you need to be dealing with this early on. But we get to a point where you've run out of time for oral iron. So oral iron takes months to correct anemia. You're looking at 3 to 6 months, and once your hemoglobin is corrected, you still need another 3 months of oral iron to correct your iron stores. Now, the problem is if you're in your late second or early third trimester and you're anemic, you've run out of time. And that's where intravenous iron comes in, and where it's absolutely critical for mothers at that point to have access to intravenous iron to correct their anemia before they deliver. This is going to touch a little bit on postpartum hemorrhage, so I'm not going to go into it, but just to kind of again raise the awareness that postpartum hemorrhage is the major cause of maternal deaths with anemia. And that is twofold. Your risk of a postpartum hemorrhage is higher if you are anemic, and you have less leeway if you have a postpartum hemorrhage and you are already anemic, because you just don't have the hemoglobin to carry that. And you don't have the iron stores to replenish that post-delivery. And the problem is blood is not accessible everywhere. And so these mothers die. What are the effects of iron deficiency? And I want you to bear in mind, I'm talking iron deficiency, not iron deficiency anemia. So even if you have a normal hemoglobin and you're iron deficient, this is the impact. Okay, so the lower your hemoglobin, the higher the morbidity and mortality. Okay, you have an increased risk of infection post-delivery. You have a decreased lactation, so you have produced less milk if you're iron deficient. You have reduced breast milk quantity in iron deficiency anemia, increased postnatal depression, decreased bonding between mother and infant, and often that is fatigue driven because you are anemic. And fatigue is a major, major problem in terms of coping. And then we move on to your last trimester. So a baby stores the iron that they need for the first 6 months of their life in utero in that third trimester. Now, if you have no iron and you are anemic as a mother, that baby has no iron when they're born. So for the first 6 months of their life, they have no iron stores. So they are anemic when they are born. And that comes with a whole lot of consequences. When we look at a neonate and the risk of a mother being iron deficient, the risk for that baby is increased risk of fetal death, low birth weight, intrauterine growth retardation, so they are born smaller than they should be. They are at risk of preterm delivery, which means they're at higher risk of a whole lot of poor outcomes. They have lower cord hemoglobin levels, they bond poorly with their mother, and they're at increased risk of infection. So these babies already are starting life completely on the back foot. When we look at infants that are born with a low birth weight with this intrauterine growth retardation, if you look at the rest of their lives and the research that's been done, they are much higher risk of non-communicable diseases as adults. And that's diabetes, hypertension, and those all come with significant costs to healthcare systems. And so a lot of these non-communicable diseases are actually preventable by correcting anemia in the mother. I know this is an incredibly busy slide, but this is the impact on a child born to an iron deficient mother for the rest of their lives. So their cognitive development is impacted significantly. They have higher rates of anxiety and depression, higher rates of schizophrenia, lower rates of getting through school and tertiary education. They do not function the way they should. And so if we can correct anemia in mothers, we can change this. Because they just, and I always say, I think we have very little chance of ever breaking poverty cycles if our children cannot learn. And you cannot learn if you are anemic, because your cognitive processing is not there. And so these children drop out of school, they're labeled as difficult, they're not taught, they're put at the back of the classroom, and they're just left. And I always think it would be a very, very interesting study to look at children who drop out of school, who get involved in gangs and all of that kind of thing. What were their iron levels and what are their iron levels and hemoglobin levels? Because I think most of them are significantly anemic. Our adolescents are incredibly at risk, and they have a whole lot of factors that all happen at the same time. They have rapid growth, which is increased iron demand. Their menstrual bleeding starts, and it is often very heavy in those first years, so they are more at risk. Their diet is poor because they are busy and they don't eat. They have higher physical activity, and a lot have early pregnancy. So they have this multifactorial thing that contributes to putting them so at risk of iron deficiency and anemia. When we look at heavy menstrual bleeding, it is unbelievably underdiagnosed. And teenage girls do not talk about it. And they tolerate it, and they use double protection, and they think it is normal. Heavy menstrual bleeding is not normal. And it depletes iron stores and causes significant anemia and has a massive impact on quality of life. Okay? I'm giving you hope. I'm giving you hope. So anemia in Africa is multifactorial. And so we have a number of nutritional deficiencies that play a role in it. We have a number of infections that play a role in it. There are genetic conditions like thalassemia and sickle cell anemia, and a lot of socioeconomic factors that come with that. So it is complex, and it is not a simple thing to address. So what are the challenges? So the challenges are limited access to screening and management, and I think that's where the greatest opportunity actually lies. There's poor health literacy in terms of understanding what anemia is. And again, when we do talks in school, we say to kids, what do you think anemia is? And they've never heard of it. So how do you manage something you know nothing about? How do you ask for help if you know nothing about it? So it's about increasing health literacy around anemia. Supply chains are poor, often oral iron runs out, there isn't any, and intravenous iron at point of care is not available currently. The cultural barriers, diet barriers, and what we spoke about a little bit earlier is the siloed healthcare. So siloed healthcare where things don't overlap. And I think our biggest opportunity is to be testing at every point of healthcare. Every single person at whatever point, if they're coming to a hypertension clinic, should be checked for anemia. If they're coming for a diabetic check, they should be checked for anemia. And so if we can go across the board and check everyone at every healthcare contact, I think we'll pick up a whole lot more anemia. And then there are big data gaps. A lot of the data comes from the global north and not necessarily from sub-Saharan Africa. How do we fix it? And that is the main thing. So we need to have a look at communities. And it was really exciting chatting to you two earlier because you go into communities. And I think the power in this is using people within communities who know communities to educate and to screen and to chat to people about what are the signs and symptoms of anemia? What are the signs and symptoms of iron deficiency? Are you at risk? Can we refer you for help? And can you be tested? Okay. And really, it's about training people who are out in the communities already using existing infrastructures. And I'm really adamant about not reinventing the wheel. We look at mothers to mothers. We look at all these amazing organizations who work in communities, empower the people within those organizations to screen mothers for something that is unbelievably common. We want to screen as early as possible in our pregnant mums, particularly if we can catch them in their first trimester. We've got a great opportunity to use oral iron, which is amazingly cost effective, but we need to do really good education around oral iron because it works if it's taken properly. And the problem with a lot of mums is that they're nauseous anyway. Oral iron gives a whole lot of gastrointestinal side effects, but if you take it every second day and you take it with some vitamin C, then your symptoms are much sort of more reduced. And what happens is they stop it because they say, I can't tolerate it, I'm not going to take it, and they never go back and get it corrected. So really, those are very proactive things we can do. Capacity building in terms of nurses, midwives, and primary care staff in intravenous iron administration so that we can give it at point of care. So you don't want to refer a mother to a tertiary hospital that may be a 3-hour drive away to get her intravenous iron because she is not going to go. And it was interesting, I went to Kailicha the other day, we're doing an IV iron project there, and there was a mother who'd been in the ward for 4 days for intravenous iron. They'd forgotten about her, and then were giving her iron. And her neighbor was on the phone screaming at her because she had looked after this woman's children for 4 days. So that is the reality of the situation. If we can give IV iron in an hour and a half at point of care on the day, that parent is not taking more time away off work and away from her children. Infrastructure, it's about the feasibility of getting iron and into clinics and training staff and making sure the infrastructure is there. And then the implementation and monitoring. And monitoring is critically important. And World Health is saying every mother should have 8 healthcare contacts during her pregnancy. Most mothers have 1 for delivery. So how can we have the biggest impact at that point in time for that mother to change the narrative around iron deficiency? We really want community-based screening. We want on-site training workshops and practical skill sessions. How do we do this? How do we give IV iron? How do we screen? How do we educate moms on how to take oral iron? And then we need to integrate, as I said, all the antenatal visits and continuing monitoring post. And it was interesting, my group, Joel and Grace and Fezu said the other day, well, why can't we do screening on absolutely everyone? And I fully agree, 100%, that would be the goal, is to be able to do this on everyone. But I think the numbers are overwhelming. So let's do it for now where we can get the most impact. And if we can correct iron deficiency and anemia in mums
the children born to those mothers will not be iron deficient or anemia. And that's where we can start and have a massive impact. And really, this is a great kind of slide just in terms of how many lives we can save by doing those kind of impacts. And really, it makes a marked difference. The Director General of the World Health Organization said something that has really resonated with me. And he said, maternal mortality is not a mystery. We know why it happens, and we have the tools to prevent it. Therefore, the question is not whether we can end preventable maternal deaths, but whether we will.
Thank you. That was great. So let's have 5-10 minutes questions, because sometimes it's easier to ask straight after the presentation. Then we go to Chris and his team. Is that okay? Please. Yeah, when come the light, people look like bats. Yeah, yeah. Who wants to go first? You guys anemic? Huh?
You spoke a bit about the side effects of oral iron. So I forgot to say my name's Astrid.
Hi, Astrid.
And I wanted to ask what those are and what one should look for if one's looking for a good oral iron supplement for oneself, for one's children. And because you also spoke about gut inflammation. I don't know if someone else is going to.
Yeah, so that's a great question.
Yeah.
And so oral iron is the older irons, and the irons that are used in state are what we call chelated irons. So they're older irons. So they release iron into the intestinal tract. Now, the problem is if you're taking it every day, you build up a whole lot of free iron in your gut, because your iron receptors in your gut get blocked by that oral iron. They take a little while to clear. When you land up with free iron in your gut, you get constipation, you get nausea, and you just feel very bloated. And so you can imagine for anyone taking this, when you're feeling like that, you're just going to stop. The other thing that has a major impact on getting rid of that free iron is vitamin C, helps to absorb, and vitamin B12 is critically important. 12 helps the free iron to become available. If you change those irons and you go to every second day, you are clearing the iron receptors in your gut, and you are allowing the iron that you're then taking that is bioavailable to connect with your iron receptors and be absorbed. That's the problem with the chelated irons. There are newer oral irons, sucrosomal irons, that are absorbed through a different pathway, but they are expensive. So within the private sector, those are the irons that we use, because you can take them every day. They've got very good bioavailability, they're absorbed really well, and they have very few side effects because there's not a lot of free iron. The problem is the majority of our population can't. So that's the education that needs to come around oral iron. So you take it every second day, you take it with vitamin C if you possibly can, whether it's a glass of orange juice or an orange or vitamin C tablet. It helps to increase your absorbency and make sure that you're not taking it every day.
Yeah.
Thank you very much for the talk. I'm just curious to know for this intervention, is it possible to use it for prevention? For example, if we have one setting, we know that we have a lot of anemia there, and we didn't have really biological confirmation of iron deficiency. And also, maybe for public health intervention, can we give to all the pregnant women just to prevent? Is it possible, or we have a risk? Thank you.
A great question again. Oral iron is pretty much given to every mother because we know that most mothers are iron deficient. It also doesn't do much harm in that time period if you're taking it, particularly if we know most mothers are good. Intravenous iron needs to be quite carefully dosed. So what the aim is to do point of care ferritin testing and hemoglobin testing to ensure this is iron deficiency, because we know that there's anemia other causes as well. So you want to ensure this is iron deficiency anemia, and then you can correct and dose really well with IV iron. And it's always a thing not to underdose. Whether that is in oral iron or in IV iron, make sure if you're going to correct something, that you correct it properly and that you ensure that you're correcting those low hemoglobin levels. It's pointless underdosing and giving someone too little because you're really not going to correct the issue. Absolutely. And in fact, I think children at schools should also be given oral iron because majority of them are actually iron deficient. It should form part of feeding schemes within schools where children are getting some form of iron supplement.
Hello, my name is Monica. Thank you so much for this really interesting talk and I think very relevant. I was wondering if there is any kind of funding scheme going into subsidizing oral iron. Personally, I am incredibly privileged, but when my doctor has prescribed oral iron, it's hundreds of rands for a month for one person. So how would any average household be able to afford that for a mother and several children?
So the iron that is used within the state sector is incredibly cost effective. So it is cheap, it is cheerful, but it does come with a side effect. So in children, that is often a bigger problem. Adults can tolerate that iron better than can. But there are liquids that children can take that are available that are much more. But it is a problem. And I think if we want to address anemia, not only in this country, but right through Africa, there needs to be governmental policy changes around the funding of both oral and intravenous. Because unless you have governmental buy-in, you are not going to get it cost effective enough to make it. You know, if you have a choice between taking iron and putting bread on the table, food on the table, you're going to choose food every time. And so it really should be, the onus should be on governments of countries to really look at this and buy in to the impact that it has on children and mothers and actually people right through their entire life.
Just two questions from me. The first one, it's for you. The other one is for the fellows that are doing the project to you, so you can start thinking. Yeah. So the first one, like, how easy test for anemia level? So do you have a kind of point of care or like a rapid test? How easy it is? Because now I want to take my children to be tested tomorrow, so I want to know how easy it is. And then to the fellows, yeah. So what's your project? What are you trying to deal with anemia? Which challenge, if you can explain us? Yeah.
So testing, it's always interesting when you look at the gold standard. So the absolute gold standard for testing for anemia and iron deficiency is actually a bone marrow test. No one's ever going to do, okay? Blood test is your next because it's the most accurate, but the problem with that is it's got to go to the lab. So then there's this lag in terms of waiting for results. And by that time, you've lost that mom. So you can do a finger prick hemoglobin, and you can do a finger prick ferritin test. And what's really interesting is the ferritin test doesn't tell you the ferritin level. It tells you whether it's high or low. What it does is classify, is this iron deficiency or not? There are situations where a ferritin is raised, but the person still has iron deficiency. And then we look at the other two markers, a serum iron and a transferrin saturation. But that would then require a blood test. But in the general population, it is a really effective, very quick, instant test in terms of, is this iron deficiency in anemia? Accuracy is pretty good. And what's also interesting is having spoken to the companies that put this out, when they package it for the private sector, they package each test individually, and they charge 175 Rand per test. You can buy it in the pharmacy. If you change it and you package it differently, that test can be done between 60 and 70 Rand. Suddenly is a whole different game changer. So the packaging is what costs it. So it's about thinking outside of the box? How do we do it to make it more cost effective?
So we had a conversation yesterday with one of the ANC healthcare people from Eswatini, and they basically validated what Karin has said, that some of these problems are caused mostly because of the knowledge gap between both the healthcare and also the women who are being served. So we decided that we want something around training so that we can also educate both the people, prepare them, because she said that some of the cases, they are mandated to check for it, but you find that the clinic or hospital itself is unable or does not have stocks to be able even to address it. So we want to first offer the training, then out a way to equip them so that they can be able now to test and then administer the iron. And we were looking at scale-up phase where we start here in South Africa first, then try to bring together, then have like a regional dossier, able to inform them.
It's not a question for now. That will be for as you go to the countdown. How you guys are gonna fund that? How you gonna make money? Yeah.
Just a quick one. When I was a schoolgirl at high school, I used to donate blood. And when we arrived, they used to prick our finger and squeeze the blood into a glass of water. And if it floated, I think they said it went to the bottom, you weren't.
Yeah. So it's basically very archaic kind of test, but yeah. So what it does is actually just show you what the iron volume is in your kind of iron within your red blood cell, and so that's why they did it. They still do check every single time when you donate, and it's amazing how many blood donors are now being put onto oral iron, and blood has become an incredibly scarce resource. And the onus is on what we call patient blood management to stop anemia so that you don't need to use blood unless someone is hemodynamically unstable. Unless you've been in a car accident and you've lost a huge volume of blood or you've had a massive gastric bleed, you should not be using blood unless you absolutely have to. Then you should be using the absolute minimum possible. When we come to things like postpartum hemorrhage, and where a mother bleeds, if her iron has been restocked prior to delivery, and her hemoglobin is normal, she, number one, has a lot more leeway if she's going into delivery with a hemoglobin of 12 compared to 6, and she bleeds and she drops her hemoglobin to 8, compared to a mother who's got a hemoglobin of 6, dropping it to 2, and how much blood you need, and how much iron you need. So the mother who drops the hemoglobin to 2 has very little chance of survival.
So we have the last question here because otherwise you're going to be there for 2 hours. We like asking questions. But...
Hi. I have a question. Maybe you may have mentioned it. You said sickle cell anemia is, I understand it's only for Africans, almost exclusively to Africans. So what is the prevalence of sickle cell and how does it really affect the numbers you have? Because I saw that there's quite a lot of risk factor in Africa. So what's the prevalence? How does it affect those numbers? And also, if one is to take iron supplements, if they have sickle cell, would that make a difference at all? Or you're just, pumping gas into a tank that just can't hold it?
And that's a really good question. So sickle cell anemia is very prevalent in Africa. That doesn't mean you don't get iron deficiency with sickle cell anemia. So sickle cell anemia, most of those patients run quite low hemoglobins, and often they get blood transfusions. Often they get blood transfusions to bring their hemoglobin back up again. But actually, a lot of them have this, or they have the same risk of iron deficiency on top of their sickle cell anemia. But it's very important to double check that what the anemia is. They're sickle cell anemic, so they're going to be lower, but is there iron deficiency? and it is not to correct until you know that they have iron deficiency. If you give iron to a sickle cell anemia patient who is not iron deficient, you're going to iron overload. That comes with a whole host. So they do get iron deficient, even though they have sickle cell anemia. It is important to correct it when they do, but you need to ensure that that anemia is also iron deficient. So about 31% of sickle cell patients are actually iron deficient.
Thank you so much, Karin. Yeah, thank you. It was fantastic. Yeah. Yeah. Thank you. So just to invite Chris and his team. Yeah. So yeah. Chris had founded a biomedical company. Yeah. What do you think that is his first degree? Question? Huh? So he has an engineering background, engineering and manufacturing, and that's how it moved to biomedical company, and his company is called Sinapi. Yeah, and Chris, with his name, Chris de Villiers, of course, has been educated in Stellenbosch. Where else? Not. Probably, are you the nephew of Vin de Villiers, our rector? Not yet. No, yeah, it's a big name. And so he went to found a company that then launched first a product that was called Synapse Chest Drain, which again, very large market share, 70% of the market in South Africa, and then start also moving to other countries, which then got over 20% of the market in Germany. So it's great to see this kind of inventions and companies moving from South Africa and start being spread around the world. But I think that what he will be talking today to us, I assume, it is about another invention and another product that is the Elave drop and Elave free flow uterine balloon. Is that right? Because that seemed to be associated to detect bleeding and save mothers that bleed after birth. Yeah, and his product Elave is now used in more than 45 countries. And so he grew as a company from here, which employ over 200 people and 80% women. Yeah. So thank you very much and welcome. Yeah. And sorry that I don't have your bios, but I'm going to pass to Chris to introduce his team.
Thank you very much. So I'm quickly going to introduce Rita to you and Temka. And I will leave it that because you'll remember Rita and Temka, not their surname. So that's good enough for now. And we want to talk to you about, so the next session is maybe a bit more practical and a bit more where we answer the question, if you start 10 years ago with nothing and you need to, in our case, develop a new product or develop an idea that you're busy with or a program that you're busy with, is what would the steps be to get to the end or to get into some form of impact. So we hope that you can relate in some way to that specific question. So Rita and Temka will explain the technical details about two products that's used in postpartum hemorrhage right towards the end. We heard such a good talk about anemia now. And now what does it, when a mother does have postpartum hemorrhage, if she bleeds, how can we address that? So that's the two products, and then I'll end with just telling you the story of concept to impact. And I think you have a factory visit with us tomorrow as well, for those that want to come. So it's very close by our factory with 80% females, and clean rooms and injection molding and engineering, etc., is close by. So we hope to see you tomorrow there. But okay, over to you. And Temka and Rita specifically dressed, before you switch off the lights, you have to see, and what you'll have to do is address what you are dressed with and where your dress comes from.
Good afternoon, everyone. Such a privilege to be here this afternoon, and we are very happy for this opportunity. Thanks so very much for all of you being here. And then, as Chris already introduced us, I am Temka with my colleague Rita, and we work for Sinapi Biomedical, and we really have a focus where we think about the mother. The mother is the whole world to a child, and we work to save that world. If you just think about it, that the mother is carrying a baby for 9 months, and even after that, the baby or the mother is all that the baby knows. So you need to think about saving that world in order for you to want to make an impact. So today, really, we want to start with telling you a story. And on the screen, you will see a mother, and we've given her the name Amara. Amara is a mother in rural Africa, and she is at the clinic and she is in labor with her third child. On this specific day, she is at the hospital in the heat, and she is waiting to hopefully see the midwife. She is one of about 30 mothers on that specific day waiting to be able to give birth. And Amara is hopeful that hopefully she will be able to get one of the 3 available delivery beds so that she doesn't have to give birth on the floor.
And the healthcare workers are understaffed and working tirelessly to try and give the best healthcare that they can to Amara in a limited resource setting. All the while keeping in mind that the global statistics says every 2 minutes a mother dies during childbirth. I say it again. Every 2 minutes, a mother dies during childbirth, and they are hoping that Amara will not be part of that statistic today.
The reality is that in Africa and beyond, motherhood or bringing new life into this world can be a life-threatening experience. As joyful as it is, there is a few challenges that mothers like Amara are facing. And sadly, one of the biggest reasons that mothers die, especially in sub-Saharan Africa, is due to postpartum hemorrhage, or in short, PPH. I'm going to give over to Rita, and she's going to explain to you just a little bit more about what PPH is so that you can really understand and grasp the intensity of why this is such a big challenge.
So PPH is one of the reasons that it's still the most dangerous thing a woman can do is to give birth. So what is PPH? PPH is postpartum hemorrhage. It simply means that the mother continues to bleed after giving birth as the uterus doesn't contract properly. Now the wound, what is left by the placenta detaching from the uterus, is still open and she bleeds. This most often leads to death, if not other severe complications. So let's look at the problem. The problem is healthcare workers are visually estimating blood loss. So what is visual estimation? They are guessing. They are looking at what they are given, if the blood is on the pads, the hospital sheets, or a kidney dish, or a linen saver. And this is already an ideal situation because the blood is only on one product. Often it is on your pads, your hospital sheets, even on your floors. And then you, as a healthcare worker, needs to guess, estimate if this mother is in trouble or not. There was a trial called the Motive Trial where they started to introduce a drape. So you can see this picture on the right. It is a surgical drape that they used for this trial, which took the guess out of the guessing game and actually gave a standardized way of measuring blood loss. However, sorry, I just want to say too much. So, because it's a surgical drape, it did not meet all the needs. But just already having a standardized way of measuring blood loss, the outcomes showed that it reduced severe PPH by 60% and reduced the need for blood and blood products by 40%. So already a big win. Problems, though, what was faced in this trial is it did not fit all BMIs. So if you had a larger mother, it would leak. Having two different plastics and seams led to leakage, and as well as the plastic type making it uncomfortable. And if you can see right at the bottom of the picture, you can hardly see the measurements. This drape could only be used on the delivery bed. And as you could hear, Amara's clinic only had 3 delivery beds. So it was not very practical for our understaffed settings. That's where the LV drape came in. We actually looked at making a drape specifically for the maternity ward, where we meet the needs of the healthcare workers for the midwife, our cleaners, and our doctors. And of course, keeping in mind logistics. So we can start, what was the benefit logistics-wise, is we made the drapes have a dispenser where, as you can see, it works like a tissue box. There's more than 100 drapes in this tissue box, making much easier logistics-wise as well as space-wise in your clinics or your hospitals. Then it's a much larger drape, minimizing spillage, actually stopping spillage, and it has straps that can attach to the mother. It can be used on a delivery bed as well as a standard bed, because not all healthcare settings had a delivery bed, or the mother had to move after she's given birth from the delivery bed to the recovery room. So this drape was designed that the drape can be attached to the mother, secure it under her breast. She can reach down, grab the pouch, because there's a handle at the pouch, lift up the pouch, and she could walk to her standard bed. And then, of course, be repositioned. Now, as we spoke about anemia, we know our mothers do suffer from anemia. PPH is defined as 500 milliliters of blood loss in your standard mother. But if they have an abnormal observation such as anemia, you must actually start your PPH protocol at 300 milliliters of blood loss. So if you can see here at your action triggers, it's very clear in large black bold that you can see 300 for your anemic patients and 500 for your standard mothers. Furthermore, we considered the safety of our healthcare workers as well as our cleaners. Because unfortunately, blood still carries a lot of diseases, such as HIV and hepatitis. So after you have diagnosed PPH, you are able to seal the blood in the blood collection pouch, minimizing cross-contamination for your cleaners and your health care workers. So you're making it much safer for your mothers as well as your healthcare workers. So, unfortunately, Amara has lost more than 500 milliliters of blood. So what are we going to do?
If a mother has lost so much blood, the problem is that you want to immediately stop that bleeding. Just think about it real quick. If I had to grab you by your arm and I just suddenly cut you on your arm, what's going to happen? You will start? Thank you very much. Someone else use your voice. You will start bleeding. Are you going to just let you bleed, or what are we going to do? Stitch up if you don't have stitches, if you don't have a suturing kit. What is that? What are you doing? Pressure, exactly. You will be applying pressure. Will you be applying pressure on the shoulder? Exactly. We will be applying pressure on the wound. So that is what we want to do when you face a case of postpartum hemorrhage. You want to do 2 things. The first thing you want to do is absolutely stop the bleeding. And secondly, you want to contract the uterus. That simply means that the uterus needs to contract to go back to its original size. Because when the uterus contracts, that wound that my colleague has spoken about, where the placenta attached, that wound closes down. So if the uterus does not contract, then that wound stays open. So out of desperation, the healthcare workers in your lower middle income countries or your low resource settings, they will out of desperation take a condom, they will take a uterine catheter and a syringe, and then assemble this to make a makeshift device in order to place this inside the uterus and attempt to apply pressure to the bleeding site to be able to stop the bleeding. Sadly, however, this is not always very effective, because let me ask you this question. What was the condom originally designed for?
Good. You don't have to answer it because I can hear that you know exactly. It's not been designed for the uterus. Thus, we needed something designed specifically for the uterus. And I want to make a second mention. This makeshift device takes about 10 minutes to assemble. That is the average time it takes for a mother to bleed out if they have been diagnosed with BPH. So can you imagine that you want to save this mother's life, but you still need to struggle assembling a device, and in that time, she is bleeding out? We can't take that chance. So really, it was clear. Africa and your lower middle income countries and the world needed a device that is easy, effective, and simple to use. And that is where the LRV uterine balloon tamponade, of the idea of it, has been born. And you can see with the LRV uterine balloon tamponade, or in short UBT, it's a supply bag with a tube, a tap, and a balloon. This device is extremely effective and easy to use. And if you can go to the next slide, thank you, Rita. You simply fill the bag, the supply bag, with 1,000 milliliters or a liter of saline or some clean water. And then you will screw on your tube. You will place your balloon inside the uterus, ensuring your tap is closed. And then afterwards, as soon as the balloon has been placed inside the uterus, you will then open the tap, and through gravity, the bag is hanging. That fluid will drop down and flow into the balloon, expanding the balloon and then therefore applying pressure directly onto the uterus wall. And that pressure is being applied onto the bleeding site, where you want that pressure to be in order to stop the bleeding, creating a seal and creating an effective tamponade to completely stop the bleeding. So as you hear, this is such an easy device. And like I've mentioned with the previous device, it takes 10 minutes to assemble. This device is already pre-assembled, ready to use, and as soon as you fill it, it takes less than a minute to fill the balloon. So in a matter of minutes, less than 3 minutes more or less, you are able to apply pressure to the uterus wall. And then a last thing that I would like to say about the LRV UBT is that this device also has an added benefit. You can use it safely to transfer your mothers between facilities. So what happens is a mother will give birth in a lower care facility, and then they don't have a theater, or they don't have specialists to be able to look after her. So then they will have to transfer the mother from the one facility to the other. And that becomes a challenge in places like Africa, with long distances that they need to travel, as well as the roads are bumpy, messy, and that is usually where they then sometimes lose the mothers. So being able to have a device, a solution available that you can transfer your mother from the one facility to the next, is absolutely crucial. And we have seen and heard the testimonials of midwives in your lower care facilities using this device to transfer the mother immediately after diagnosing PPH, and that mother coming to the next facility, and they don't have to do anything else except to monitor her because the bleeding has been stopped. So all that needs to happen is the uterus needs to start contracting. And then here is the really amazing thing about this device. You've heard your professor? Yes, you've heard your professor say the word free flow. The LRV UBT is a free flow system. That means that as soon as the uterus starts contracting and that tap stays open, the uterus will contract onto the balloon, and the water inside the balloon will flow back to the supply bag, allowing that contraction of the uterus to happen. And the other amazing thing is you can control the pressure that you are applying by simply reducing or increasing the height of that supply bag. So if you think science-wise, the higher that bag with the hydrostatic pressure, it will be a higher pressure being applied onto the uterus wall. A lower bag will then have a lower pressure being applied onto the uterus wall. So that is the absolutely life-saving benefit of the LRV uterine balloon tamponade. So with these two devices, the LRV drape And the LRV-UBT, Amara's life was saved because the LRV drape was used to early identify and diagnose postpartum hemorrhage. And since a trained midwife had the LRV uterine balloon tamponade available, they were able to deploy it quickly and seal off the bleeding in order to save that mother's life. And I'm going to give over to Chris because he will be sharing with you how we get these products into Africa.
Thanks. Just quickly tell us how many. So we designed the drape in I think 1 year's time. We launched it about 1 year from now. How many have we sold? What 1 million?
More than 1 million, almost 1,010,000.
Right. So more than 1 million drapes went into Africa, and the uterine balloon tamponades. How many this year? I mean, yeah. What would we?
This year, we are at 43,000 LRV-UBTs within Africa.
Okay, that's in 45 countries, I think, in Africa alone, and 42, sorry, not 43, 42. And it's Rita and Temka and a colleague in Benin and another colleague that's doing this. So it's not a massive team, it's a small team that's making sure that we have that impact. Thank you very much. So my portion of it, just quickly, I'm not sure how long we've got left. 10 minutes. Okay, my talk, yeah. So what I thought could be valuable is this, you now see the technical, or you saw the technical portion of it, and I think my role in Sinapi today is more to kind of think we need to have a concept, and we started with the uterine balloon tamponade development close to 10 years ago. So let's say in 10 years' time, how did we get from concept to having impact? So hopefully some of you can relate to that in where you work today. So I just thought to write down a lesson or two that for us was really important. So within the medical device space in South Africa, and very much so in Africa as well, there are not many examples of companies that actually start and get the funding and make it and get through the regulatory requirements, where I can't tell you how expensive it is and how long it takes to get these products through regulation. They are both CE marked and FDA approved. And but to get there is a long and hard road, and there's not many good examples yet. I think there's a lot happening in Africa within the medical device space, but currently the examples are still low. So I think the first lesson for us, or important thing that comes to mind for me, is it's got to be a calling. So what we're busy with, or I think, Karin, what you're busy with, or what you guys might be busy with, I think a good question to ask yourself is if this is a calling or not. It's such a privilege for you guys to sit in this room. I think we're all so privileged to have had the opportunities that we've had. I've got more than 2 shirts. I have a toilet that flush. So that's huge. We are so privileged, but we need to follow. I think the resistance would be so hard. If you're not convinced that you should do it, you might give up. So that's the first thing. The second thing that it really worked for us in terms of the products that look really simple, but I promise you they go through a lot of design iterations and thinking of why they look the way they do. But market research is really important. The first product, we had the privilege of working with a partner from Seattle called Path, and they helped us to get a whole lot of specialists in a room, and for a day we could, as engineers, ask what this balloon should look like. So that really just sped up the process of design and development, and we learned from that and applied that with the drape as well. Rita, I think we tested how many, I can't remember, it was 700 patients went through the test on the drape. There's more than 100 iterations that the drape went through. So today would look simple, as actually took a long time to get there. So that's really important. And you don't know, if you're an engineer or you're designing anything or busy with any project, you don't always know. You always have a client. It could be internal or external. and your client have needs. The client has needs, so you need to really know that. So that for us has been a really important factor. The next one is the word creativity. We love being creative, and I think in the room, I hope I've got people that share the love for creativity. And living in Africa is actually such a good place to be creative, because we have a lot of constraints, and constraints births creativity. So 2 examples. The one you saw, the example of the uterine balloon tamponade that Temka called a free flow system. So it's really simple. It's a balloon and a bag that hangs higher than the balloon. But so the market they wanted, if you speak to trauma surgeons, if you bleed, as Temka explained to us, you want to stop the bleeding by applying pressure. So we knew we needed to apply pressure in the uterus to keep the blood inside the vascular system. You have a pump called the heart that's applying pressure, and you just need to ensure that you apply more pressure than what the pump can provide. And we know what that pressure is, because that's blood pressure in millimeters of mercury, and we need to apply more pressure. But then if you speak to obstetrics and gynecologists, they say, no, we don't want to put a balloon in the uterus, because that's going to is going to keep the uterus open, and we want the uterus to contract, because the muscles contracting is actually what's stopping the bleeding that's what's stopping the uterus from bleeding. So you've got these 2 things working against each other. So the solution was to have a free flow system where you have height or hydrostatic pressure, and you still allow the uterus to contract. And once we've got that sorted out, the trauma concept as well as the obstetrician and gynecologist were happy. The other example of creativity is the drape, where if you start using drapes on every single birth in Africa, this is going to cost a lot. So how to reduce that? So the process of manufacturing that you will see tomorrow as well, I hope that's running tomorrow, is really we needed to make sure that the production process is really inexpensive. And then secondly, the transportation of a device sometimes is more expensive than the device itself. So we designed it that it's manufactured from a roll to a roll, and we package in a roll. That our packaging, the drape that we do, the LV drape, packages 20 times as compact as other drapes. So we get 62,500 drapes in a 20-foot container, for instance, and other drapes, competitive drapes, would be between 3,000 and 6,000. So our transportation is less than 10 US cents to get it to the client in Africa. So that really helped as well. So that's just about creativity. And then the other aspect about impact products. The client in Africa, there's constraint in terms of resource for funding. So it's hard as a commercial company to say that we're going to invest a whole lot of money and then make sure that we get paid one day. So the partnership, this line for us, we had to do in partnership with the likes of PATH, the likes of the South African Medical Research Council that funded actually I think 3 clinical trials on the uterine balloon tamponade, then Johnson & Johnson, and now with the drape, we work with the Gates Foundation. So that's, without that, it's just not, you're not going to, as a commercial company, single-handedly change Africa. So that thing of partnering is really important. And I think then just the second last is to have your team. It's a lot about teamwork. You can't do it alone. But you have to really work together and have grit and discipline in what you do. So you saw the communication material, the marketing, and the training material. We have to get onto planes. We have to go and live in Africa. We have to go and do that training over and over again. Next slide shows that. There we go. That's the evidence. So just to share that's what it takes, but I think the message is the repetition of the same thing. I think as academics, we really like the new and the latest thing, but sometimes it's actually just taking the discipline to do the same thing over and again. Yeah. And then the last thing is just, or second last again, is good communication, which I think is the marketing message that really has to be good. And then lastly, I started off by it's a calling, but then also there's a faith aspect to it. We within Sinapi, we say that we have to have faith for what we know where we are going, because we're going to what you can't see yet. So you have to really believe that you're going to get there, and then we're grateful that we've seen some of it. Right. Hopefully that's it. Thank you.
I would just pass around. I'm sure that there's a lot of questions. Yeah.
Hi there. Thank you so much for your talk, and thank you, Karin, as well. I think the work that you guys do is absolutely amazing. And as somebody that's actually living in South Africa, and I'm hoping that other people in the room and maybe online will hear, but I'm asking, is there any chance that even as an individual we could help with training support or in any way? Because yeah, I would definitely love to be more involved in helping. So is there anyone we can reach out to, or email, or?
Oh no. Okay, great. What kind of help?
Any kind of help. I mean, training, volunteering, honestly, I mean, we have limited time, but in whatever way, I don't know. I think every person can, even if it's an hour a week or whatever, can contribute and help. So yeah. In my head, I was thinking volunteering, going to these communities, doing training. Yeah.
Well, that's a great question, and sure, thank you for a response like that. It's really wonderful. So yes, there would for sure be opportunities to assist hands-on or remotely as well, because we do a lot of research, clinical research. So there's for sure opportunities. So I would suggest please connect with us.
I can see what Charlene. Yeah, she wanted the dress like that and be going around Africa to train people for that. Yeah.
Thank you very much. Good afternoon, and thank you for both your talks, Karin and Chris. I'm curious about uptake of the balloon product and the drape. I think it's the drape, the initial one, amongst mothers. Because as a woman sitting here, I was just queasy the whole time. So I'm imagining that, I mean, yes, it's life or death, but exactly how do you go through the challenges of making sure that women are keen to use the products, especially in a Southern African setting? Thank you.
Luckily, I think in healthcare, the queasiness eventually goes away because it's the reality that, if we bleed, we need to address it. But with our product development, especially on the drape, it was important to get feedback from mothers. So we start off, let me take one step back. You start off with the healthcare provider, being nursing sisters, midwives, doctors or specialists. And that's the way what we see is we serve the heroes that help the critically ill, but so you get feedback from both. So for instance, the drape, the initial feedback was, is it not going to be cold to sit on a drape? But that I think we've had a small amount of resistance because of that. But once mothers realize what we are doing, they say, well, we're happy to sit on the drape. The benefit of the drape is really when you measure, you can treat and you can react to the problem. So this emotive trial that Rita was referring to showed in 5 countries, 80 hospital settings, well funded by the Gates Foundation, showed that when you use a drape, severe PPH was detected 60% more. So that's really something that you could work with. If it was my daughter, or then I'd want her to use it. Please see that she's bleeding. So that kind of in that case was more important. So yeah, but so I hope that would answer the question. You know, the balloon, for instance, that the mother now needs help. You know, so you're not going to. She's not going to ask questions. She needs to survive and be there for her child. So that wasn't. That was more clinical research phase.
Okay, thank you very much. Just a question concerning the cost, because we know that a lot of mothers have to give birth in some rural settings. And also concerning your strategies, do you think that is proper for the government to buy for them, or this have to be paid by patient? I don't know what is your strategies, but I'm just curious about the accessibility to the cost, because you know that concerning the mother is a lot of poor families who have these issues. Thank you.
I'll quickly answer, and please add if you want to, Rita or Timka. So it starts with for the uterine balloon tamponade. When we started with the project, we knew that the commercial products that's medically regulated was costing $200 for one balloon. And we saw that in Africa, with creativity, they used a condom with a urine catheter that's costing almost nothing. So the task that we had was to provide a medically regulated device that's very close to almost nothing. So the target price was $5 initially, and then $7.50, and we today sell it for between $7.50 and $10 compared to $200. So, and then again, the uterine balloon tamponade is used on 5% of births at most. So it's not a massive burden for a government to take. It's really for your critically ill. You've been anemic, so unfortunately you didn't succeed there. You didn't succeed with the uterotonics, and you now have to, what we call, the patient need to be treated for refractory PPH. It's a small volume, so that's in our view really affordable. The drape that was used with the emotive trial cost $2. That's where drape started. We launched ours at 80 US cents. We're down to 70 soon, and we believe that it will be down to half $1 within 2-3 years. Not just from Sinapi, but from other producers too. So it becomes less and less expensive. We're also working on what we call a durable drape that you can use more than once. To your question with regards to does government or patients pay, depends on the country. Some countries like Benin has got great funding, so it's funded by not the patients, and then other countries like Nigeria, for instance, we expect it would be a combination. Kenya as well, there'd be private and public funding for it.
And just, we have another question, but before I give the microphone, just to say, and that the importance of what he highlight of this mix business model of applying for funding, sometimes for philanthropic funding, to build a business, and then after to sell, and sometimes we may also sell for to a funding, to a foundation, and that's very common, and that's one of the reasons why we also provide you guys with training on grants management, grant writing. So that's exactly the way that we are doing with Fluorobiotech. So tomorrow we have an event with the GIZ that funded the initial development. I understand with you was the same with the South African Medical Research Council funding the clinical trials, and then the gates come on some of the implementation, and PET, you say PET. And that's really important that as one develop, one really think about this business, mixed business model.
Hi, I'm Harris. Just thank you for the talk. So I wanted to ask, what challenges did you face when you were implementing these products in so many countries when it comes to their regulations? And how easier would a harmonized regulatory system make it to implement new medical devices all across Africa?
So the challenges are exactly that it's not harmonized, that essentially the long-term game plan in Africa is that for relatively small economies, you've got to go and register every product individually. The next challenge is you need to have a local company doing that for you. So unfortunately, with the distributors in Africa, if they buy from us and then sell it on, they have to mark the products up by 3 or 4 times as much because their markets are so small. The buyers are not high enough. If we sell in Germany, if we sell for $10, the distributor would sell for 20. In Africa, they need to sell for 40 or 50 to pay their staff because the volumes are so much less. So the distributor has a big challenge, and then we now have the challenge to have to work with the distributor to register the product. So that's a long story how to overcome that. Should those standards be harmonized in Africa, let's say the same size as India, that it would be a lot easier. So that would definitely, and I think there are plans to do that. I'm not sure if you're involved, but we've not seen a lot of progress, but we hope within the next 5 to 10 years, we will see more harmonization. It would help a lot. Yeah, and then one thing to add is what's helping us currently a lot is some NGOs have waivers that they can get products into Africa. For instance, we listed with UNICEF, we listed with UNFPA, so we listed with Doctors Without Borders, Partners in Health, so they have waivers to get products in. That does help a lot, especially for impact products.
Okay, last question, so we start and finish on time.
I have a question related around data. As if I could ask you to pull up the footprint slide.
Footprint.
So we always hear this this question around that the health data in the African setting is often not recorded enough. And from what you've told us, that you have a way of collecting the blood, but you dispose it. Have you thought about maybe using it as a revenue source? Someone like Prof. Tulio, blood could be. I'm sure this blood could be of use somewhere because you are collecting it from almost all African
countries. So blood recollection or auto transfusion, we do that. The other products we do is a chest drainage device. It was also started in Africa where we see a lot of chest trauma. So there's a huge need there to retransfuse blood. So we do that. Our products allow blood transfusion. In the maternal health space, we see a big opportunity after cesarean section. That's just the volumes of cesarean sections are a lot more. So we're working on products to retransfuse. The problem with the birth process is the amniotic fluids. If you mix the amniotic fluids in the blood, you actually have to spin it out or use a cell saver to then harvest the blood. So I'm not sure if that was your question specifically, the practicality around getting the blood back.
If I understand his question, so for example, each time that they use the drop, you call it
the drape, yes.
Drape, yeah. For example, if someone could record how much blood the woman lost, that could be important data for research to have idea of like average, blood loss, and then you could potentially test for anemia, that potential, that could be important source of data that could even motivate more, or because a lot of time we lack that kind of data.
Yeah, I think your point, I think it might be something that you call to do. I'm not sure, but it's actually there's a lot of opportunity to use data more. We spoke about it briefly before the presentations. Is if in South Africa there's so much opportunity to use clinical trials. So in the clinical trials, the data is well collected. We for sure have access to that, and then you can do implementation trials where you can collect more data. but to use the data is actually also really important. To start at the end is where do we want to make impact? Is it with the World Health Organization, or where do we want to, or with clients or patients? But so there is a huge opportunity to use it more. But I think that it's quite a lot of data on PPH, on anemia as well.
I think what's really exciting around this is, again, the siloed stuff and the opportunities within Africa to use existing infrastructures and existing devices combined with other things to have a greater impact. And I think if we're ever going to address issues like this, I think this is incredibly exciting. And it's again, as I said in the talk, it's not about reinventing the wheel. It's about what is existing and how do we almost piggyback on what's existing to improve outcomes even more. I think that's the exciting part. It really is.
Okay, what a phenomenal way to wait the seminar. Please, another round of applause for a great present. Again, thank you very much, for coming. And I think that all the fellows and our team appreciate, it gives a lot of ideas. And we really look forward tomorrow for the visit and to further engagement. Thank you for being a mentor, and that's great. And then my next big important thing, MB, can you put on the WhatsApp from both our CERI and the African Stars the link for the YouTube? We're going to be having the launch of the Climate Change and Epidemics report.